Okay, so we will start. Good afternoon, dear madams and sirs. I'm happy to welcome you to this afternoon session. My name is Tim Eckmanns. I'm who? I'm the head of the unit of surveillance of healthcare-associated infection and antibiotic resistance and antibiotic consumption surveillance at the National Public Health Institute in Germany, the Robert Koch Institute. So we are doing, or I'm doing since 10 years, surveillance, but the surveillance of infectious diseases. But currently I'm working at the WHO headquarters in the Ebola response and just coming back from Sierra Leone. But be killed, I'm here for more than 21 days now, so I'm not infective, so it's safe for you to sit next to me. The world is changing and surveillance in infectious disease is changing a lot in the last years, but we are public health people and we are very much interested in changing surveillance systems, but we know that there are a lot of challenges, and that this is not only a technical change, but this is more than a technical change if we do new kinds of surveillance. And that's the reason that we have this panel here, opportunities and risks of data, of big data in disease surveillance. This is a big question for us as a public health institute, and so we need more people, other people who discuss this with us, not only public health people. And especially we have questions, will big data lead to an epistemic shift from more statistic to network analysis? We hope to hear about this some more today. What will be the consequences of such a shift? Will big data lead to a change of priority setting in public health? What are the implications for privacy and discrimination? There will be, we think, some implications. And what will be the ethical and social impact of such a change? In Ebola has shown to me that in the moment there is not so much help of this new way of big data. We get no earlier information. We have the same old problems that we got too late this information, but it will be a change. In September, the Robert Koch Institute, together with the Technical University, will have a colloquium, a one-week colloquium about digital epidemiology and its ethical, legal, and social impacts. We will launch the call for paper soon, so we hope to see one or another of you in Berlin. And now I'm happy to hand over to Dr. Hempel from the Technical University, and we are very happy that he will moderate this session, and thank you very much for all the speakers who will tell us more about our questions. Thank you.
Okay, yeah, my task here is to moderate and to introduce the speakers. Thank you all for coming. We have 4 speakers, and we will somehow start the session with the organizational point of view, so with Edward Velasco, and then continue technology, the legal, ethical issues, and then I would say with the practitioner point of view, or no, with a practice theoretical point of view, more or less from Martin French, or an STS point of view, on the topic of digital epidemiology. And yeah, Edward is working for the German Public Health Institute, the RKI in Berlin. He's trained in social epidemiology and has a PhD in medical science as well, so it's really interdisciplinary here. His current research interests focus on improving management of hospital outbreaks of resistant pathogens with social network analysis, and measuring antibiotic resistance in the community and innovating in public health with new technology for surveillance. And the title of his talk is Big Data and Public Health Practice, New Science, New Practice, New Policies, but he's using a question mark. So thank you very much for coming.
Thank you, Leon. Dr. Hempel. Thanks for the introduction. Like Dr. Hempel said, I'll be speaking a bit from an organizational perspective, being a public health practitioner and epidemiologist. First off, I'd like to establish a background for public health practice. I know some of us in the room are not public health professionals. This is a field that occurs before a social backdrop, one that's been labeled differently, one being something called the social ecology for infectious diseases, stating that human activities or states enable viruses or microbes to disseminate and evolve, creating favorable conditions for different manifestations that bring about communicable diseases. There's a premise here that things like poverty, nutrition imbalances, and pollution do affect infectious diseases. Despite advances, infectious diseases persist and are a cause of a third of worldwide deaths. These are also the second cause of global mortality and disability. Inequalities persist. Public health practice, however, has an established imperative. I wanted to mention that the WHO declared already in 1946 that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. But this is beyond the control of any single authority, obviously. We recognize that this is something that has to be dealt with in an interdisciplinary way. And so we work with our colleagues in medicine, political and legal fields, as well as public health, and also others, as increasingly is the case. Right, so as part of the previously mentioned WHO declaration, there are specific mitigation activities that have been sponsored widely, from epidemiological surveillance, providing things like clean and safe water, oversight over travel and goods, regulation of food, blood and pharma, vaccinations, and the treatment of STDs. At the top of this list is surveillance, and I know that there are other professionals here working in surveillance, so I wanted to define how we look at surveillance. We see it as the ongoing and systematic collection, analysis, and interpretation of health-related data. This is to prevent and control infectious diseases, to identify unusual events of public health importance, but we're also looking to disseminate and use information for our practice. Public health surveillance is a critical public health practice, and it's a fundament of a healthy population. And I just want to say that we recognize that the integration of science, practice, and policy is critical to creating change in our field. So we have two types of surveillance that we conduct. One is called indicator surveillance. Infectious disease with indicators is conducted with data obtained directly from official reports. It's partially mandated by law. Some of these systems are designed to collect and analyze structured data based on protocols tailored to different diseases, and we as epidemiologists tend to calculate incidence, look at seasonality, and things like burdens of disease. The goal is continuous surveillance to find increased numbers and clusters that might indicate a health event. There's generally a time lag between the occurrence of an event and its detection by indicator-based surveillance. These can be slow to detect potential health events that may be arising, and can often be ill-equipped to detect unexpected cases of new disease occurrences. So this leads us to look at different types of surveillance, new types of surveillance, and something that arose already more than 10 years ago is infectious disease surveillance that's performed with data obtained directly from witnesses of real-time events. These can be sources like internet and social media, news media sources, or established alert systems. These are also designed to collect and analyze additional unstructured data in addition to the structured data we already collected at the Institute. Our goal here again is improved surveillance. How can we maybe have a faster connection to patients, or provide more data linkages between patients, medical practitioners, and authorities? We also think that we can lower costs and reduce administrative burden, and that we might again be able to faster assess and respond to health events that arise. Generally, these have been seen as faster because they decrease the time needed to first detect an infectious disease event. Timing is important, and this is an interesting quick diagram showing the time needed to recognize an infectious disease health event. Event-based systems theoretically can speed up the time to recognize an important public health event. And here you see on the right what we think could be a sort of generalization of the time to detect a health event with an established sort of sentinel surveillance system or our established government systems. With existing event-based services, this is based on a project back in 2009, so it may be a bit dated. We've seen that the time should be reduced by a few days, and at the time of one of the projects we performed, we were interested in, again, these different data sources and how they might increasingly reduce the time needed. So our work thus far with event-based system shows that they are faster, but this comes with a big maybe. There are issues with language in retrieved information on events. We've had issues with semantics and ontologies. Another issue is the authority of the information sources that we collect. Sources are not always moderated by professionals. We also think that automation was problematic in some of the work that we've seen so far, since algorithms and statistical baselines are not well developed. And systems encourage unknown changing technical and social paradigms that we've seen. These are new tools with new sources, with new users, and these are tools with new uses and new users. This will continually arise as it has done so far, leading us to question whether or not these new tools might change some of the ways that we prioritize our science and public health. Right. In response, we acknowledge that new areas and technical advances will continue to arise. Increased alternative data collection methods, internet data, sensor technology, smartphones, mobility and travel, these are all new potential manifestations of these technological advances. Analytic methodologies like data tracking and new social network analysis, as Dr. Eckmanns mentioned in the introduction, will continue to be important. And we think maybe things like intelligent surveillance, using algorithms to detect early indicators could become more and more relevant. We think associated challenges will also persist related to unknown infrastructural investments in our staff and our sort of investments in data storage possibilities. The speed and volume of data obviously changes due to internet data, as I've mentioned, from sensors and smartphones and whatever else we might see. And we may be encountering, again, a sort of new territory in ethical and social dynamics. A collection of new forms of data have also new implications for privacy and data protection policies. These are sort of new areas for us. In response, political decision makers, publicly funded organizations like ours and public health practitioners like myself do need to adapt to innovation. We have to test new methods, new data sources as a regular part of our public health surveillance programs. This may seem like a given, however, there's a bit of a circular dilemma in our practice whereby we really want to see integration rooted in effectiveness studies, but these studies tend not to exist because the only way effectiveness studies can be performed is if they're already integrated. So that provides a bit of a dilemma. Part of this will be also to respond to change. How can we better participate in interdisciplinary debate like the one we're at today? And this will require us to increasingly be aware of a role as data gatekeepers of sorts. This is a stretch for us. It means we look beyond our science and medicine and look at having social ecology and inequalities remain central, asking questions about whether or not we're using data for the right use. Are we being protective or exploratory? And we also need to be informed of politics, of data and data management. Right, so to summarize, but also to look for help from others to enhance our work, really. We recognize that new data will lead to new methods, as I've mentioned, and also new interpretation. This could mean changes to our science, changes to epidemiology. It might be accompanied by changing stakeholder roles as well. We do see an idea that there might be something like an iterative innovation in the transfer between technology and public health practice. But we look to our interdisciplinary colleagues for help, especially with the treatment of new data. How can this be responsibly managed and regulated? How can patient data be prioritized? Also, privacy. Maybe this could be due to, as I've mentioned, privacy, patient data protection aspects that are more complex given the new technologies at hand. And of course, this is related to a continuously emerging ethical and social strata regarding the new data acquisition methods we're seeing, and really the expectation of us to use these methods. We also expect that action regarding new data and methods can really translate to policies, but established and new policies will need to address public health practice needs. This would be by providing access to data sources on the one hand, and on the other hand, really enabling a co-creation of policies for the treatment of data. Right. These should also be policies that are disseminated to us, either via guidance on digital developments. There's some work that's been done looking to government committees and bodies to do this work. I'm sure our colleague Jennifer Cole can talk a bit more about this, but I know that there's a UK body called Strategic Information Governance at NHS England who is serving as a committee to work on such efforts. And you know, there are also other partnership possibilities. We could look to the work we're doing now with universities to look at really finding consultants to help us with data security and compliance issues. But I also think that public and private solutions are also out there. Ultimately, we're looking at an aim for transparency in the work that we do. Good, I think I'm out of time, so thank you.
Well, thanks, Ed. And when we set up this panel, we thought it's good to have first an organizational view, somehow opening up the problem space as such, and posing questions. But now you will have one or two the option to ask a question back to Ed as well. Are there any questions? Otherwise, just note them down, and finally we will have a question and answer round at the end of the session. But opening up this problem space implies that, you know, we think about, okay, how can we continue, how can the future look like, and therefore we thought it very important to have someone who is specialized in the technology, in the thinking of, is there what we call epistemic change from statistics to correlations to network approaches, and therefore I'm very happy to introduce Ciro Cattuto from the EASY Foundation, the Institute for Scientific Interchange, which is working strongly on these questions. We are all around and challenging these days in terms of understanding complex phenomena and systems that entangle human behaviors and digital platforms as Ciro is doing it. He is interested in computational social science, human mobility, data science, infectious disease dynamics, and digital epidemiology. And he currently leads the data science laboratory at the EASY Foundation, where he also serves as a scientific director. And he is also a founder and principal investigator of the social patterns collaboration. And being a social scientist, I'm very much looking forward to listen to you.
Thanks for the introduction, and thanks for having me here. I'd like to thank the conference organization at RKI for organizing this panel and inviting me. I will give you a quick map of what's new, a couple of peeks at the future, a quick zoology of systems that are changing and defining what we call today digital epidemiology. And I will try to place this on a map and discuss that a bit. I have a lot of slides, otherwise it wouldn't be a big data session, right? So the big picture is the following. For the first time as a society, we have the capability to compute on a digital image of the world that tracks the world almost in real time, almost at scale, with a resolution of individual behaviors that is unique. Now, this is a huge opportunity, of course, and otherwise we wouldn't be here speaking about this. It also brings forth a bunch of challenges. The domain where it enacted a lot of innovation already, which is changing the landscape, is in mathematical modeling, because mathematical models can be now run on top of a very data-rich landscape, and we have the capability of actually making forecasts and checking very fast, ideally in real time, asymptotically, whether our predictions are matching what we were imagining would happen, and checking this against reality, calibrating the models, constraining the models dynamically, right? So to give you just an example, this is related to a project run by Alessandro Espignani and collaborators at the ISI Foundation, funded by the 7th Framework Program. And it's about forecasting pandemics that are transmissible through the classic airborne route. So imagine something influenza-like. In this case, the model consists of an entire map of human population on the planet coming from NASA, commuting flows obtained by contacting each and every transport authority on the planet and integrating them on top of this data. And on top of that, data from the IATA, they give you the flows of people in the planet, right? So you have an entire map of mobility at the planetary scale that then you can combine with a mathematical model, imagine an SIR model or something more sophisticated, and by plugging the two into each other, you can then start initializing the system with what you know about the initial conditions. Of course, you need to run several stochastic instances, and you end up with forecasts. So, for example, back in 2009, the group of Espignani and collaborators tried to predict the anomalous peak of the H1N1 pandemic, right? So they published this article, and then they crossed their fingers for a couple of years while the official data came in, and eventually they combined the two, and they could assess whether the model actually was predicting correctly the exact week of arrival of the pandemic peak and when this was working, when this wasn't working, okay? So this capability, I'm mentioning all of this just to show you that in the future we will have systems that by using huge amounts of data coupled to state-of-the-art mathematical models will be able to give you a trajectory in real time of phenomena like pandemics, the same way today we track the evolution of a tornado or weather, right? And we constrain and continuously update our knowledge with what we see. So this is one example. The other example, instead, let me bring you from the planetary scale down to the micro scale of what's happening in this room right now. It's good to know you're not infected. So it's what will happen and what's happening today in hospitals and in other situations where individual face-to-face contacts can be a proxy for transmission of a pathogen, we start to be able to use sensors to track these kind of relations, right? So, for example, this is work I've done with the largest children's hospital, the group of Alberto Tozzi in Roma, and what we did back in 2009 was to wire up an entire ward of the hospital where they treat respiratory infections and put sensors on people. These are proximity sensors, and map out the network of interaction between everybody in that space, right? So you see the doctors, the children, parents, and you can use a bunch of techniques from machine learning, good old statistics, social network analysis. There is a lot of different tools that you can bring to bear on this problem to actually learn more about what's happening there. And then ask questions such as, can we restructure the shifts of the nurses? Can we redefine cohorting in order to make this network more resilient to invasion? Can we cross-mine this kind of data with standard surveillance on nosocomial infection? Imagine multi-drug resistant organisms. and try, like we did, for example, recently in Lyon, to cross-mine virologically confirmed infections and mobility and proximity of people and identify specific contacts that are at risk, right? So this is another direction where we'll see a lot of work, and as you imagine, here we really track the mobility and the individual interaction of people, and we link this to the electronic health record. So as you imagine, there's a host of problems to deal with, both in terms of the science, but also in terms of how you bring this to actually function inside such a complex organization as a hospital, right? Now let me show you a bit of zoology. I'll just refer to some, to some literature. I don't have the time to be comprehensive, but I will show you 2-3 results that define specific patterns for digital disease detection. And there are roughly 4 broad categories that I think are relevant in terms of this. The first one, and actually most of them, are based on digital traces of human behaviors. The very fact that a lot of the transactions, a lot of the operations we do in our daily lives are technologically mediated means that somewhere there is a digital trace of these actions, right? Right now, the phone operator who's serving our phones has got in their database the notion that something is going on here because there are a lot of people and they are all at the same time served by the same cell, right? So mining this kind of digital traces of human behaviors provides new analytical and forecasting capabilities and comes with minuses and pluses, right? So the problems are that, if this were physics, I'm a physicist by background, this would be cosmology. You only have one instant on the system, you cannot create a control case, you cannot reboot the universe to see what would happen in a different history. You are forced to be on Earth, you cannot see the universe from Alpha Centauri, you're stuck on Earth. So, and you have an historical perspective. You have a lot of data coming to you, but they're all speaking about the past, right? The only good thing about this is that these data are digital, so we have become very good with computers, right? So we can use machine learning, statistics, data analysis, a lot of new methods to bear on these problems and extract knowledge. So let me show you like 3-4 patterns, as I said. The first ones are passive techniques, where you use behavior such as people looking up symptoms on Google, or people looking up articles on Wikipedia and clicking in Wikipedia as a proxy for their interest and their engagement to specific health-related topics. You all know the case of Google Flu Trends, right? This was created by Mark Smolinski back in 2008, actually. And this was revolutionary in the sense that they showed that it was feasible to use a rather remote proxy, like the search behavior of people on the web as an indicator of the prevalence in a syndromic fashion of flu in the general population. Now you know that this came under fire recently, rightfully, because the big problem is that there is a lot of black box machinery going on here, and not the entire pipeline bringing from the data to the model and to the forecast is actually known. And on top of this is all based on data which are proprietary. These are data that only Google has got. These are not public data, right? So there's a lot of, I think the only good thing is that this started to question big data in the community, because it's a term, I think it's overhyped, and it's just time that we reason on putting it where it belongs, right? It's yet another source that we will use in the long run together with the rest. It's remarkable to recognize that you can do much better by using an even remoter proxy, which is the way people click on flu-related articles on Wikipedia. This was done recently by John Brownstein and collaborator. And what they did was they showed that you can actually infer the official surveillance curve from the CDC by using this funky proxy of people clicking on Wikipedia, and it works very well, okay? These are big data. These are really a huge amount of clicks, of actions, of interactions between the entire population in the US and the digital artifact, which is Wikipedia. The data are public, but these are daily data without geographic metadata attached, okay? So you can only compute that curve there. Now, the challenge is how can we increase the spatial resolution of this? And increasing the spatial resolution means that you need to pinpoint where people are in space. So you need to use the IP. And there is an ongoing proposal by Sara Del Valle, people at Los Alamos, to actually create a dynamically calibrated spatial coarse graining system to actually provide spatially resolved data and still preserve privacy and prevent identifiability of users. Another standard pattern is to use user-generated content. Stuff people write on the web, right? So there's very nice pioneering work by Marcel Salaté on using the mood, the sentiment of Twitter messages to infer the attitude towards vaccination in 10 macro regions in the US. And the result is that you can actually learn a lot about the vaccination rate you can achieve in a given region by just measuring, by using natural language processing techniques, what is the feeling, the attitude of people towards vaccination as a whole. Okay? And this is, again, surprising, interesting. Yeah. Then there's somebody earlier mentioned, for example, the capability of tracking individual users to predict at the individual level, events related to depression and mood swings and mood changes. You all know the work of Health Map, where they basically collect public news sources, and they use a mix of machine learning and natural language processing and curation, a lot of human curation to create a dashboard that surfaces health events. And there's a very promising rise of volunteer-based platforms. One of them is called InfluenzaNet. It was created by the EpiWork EU project. And it's just a set of web-based surveys where people, a cohort of volunteers, every week reports on their health status, in this case related to flu. So they got web questionnaires, they got an app, and they've been growing and growing, and now they have like 50,000 volunteers throughout Europe, and they're starting to create the first European social sensor on the prevalence of flu. So let me wrap it up by just showing you this diagram. Here, all of the systems I mentioned, they're organized along two axes that are not really scientific, right? On the vertical one, you got the general availability of those data sources, top to bottom. On the top, you got data sources you can access to as a researcher, as an agency. As you move to the bottom, you got increasingly locked data. And on the right-hand side, on the left-hand side, the horizontal axis tells you the level of engagement, the level of awareness, the level of activity of a user with respect to the platform. And as you see, a lot of the activities, I just want to notice three things about this diagram, that a lot of the activities happening on the left-hand sector. So a lot of this data collection, mining, forecasting is happening on data collecting in a passive fashion without the awareness of the user. The second thing is that the only bridge between the right-hand side and the left-hand side is smartphone apps, wearables, platforms where the user can decide in a granular fashion what you're contributing to which project. Think of all the health monitoring apps, all the application coming from wearable devices, Jawbone, Fitbit. And as you move to the left, you get data that are more and more sensitive, but also more and more locked in. And this is, in a sense, the real danger sector, right, in many ways. Not dangerous, I don't want to. It's really where we should reflect. And on the bottom left side, you have insurances. Insurances, as you know, they're doing a lot of data mining, especially when you have a private health insurance system like in the US, a lot of predictive data mining of very sensitive health data. And all of these activities happening outside of the public discourse, but it is affecting society, right? Because there is a lot of work being done in behavioral change there. So let me close here, and if you're interested in this kind of topics, let me just mention that with John Brownstein, we are organizing a digital disease detection conference for the first time in Europe in May. Thank you.
Okay, thank you very much, Ciro. Are there any immediate questions to Ciro? Okay, if this is not the case, or over there, please pose your question.
I can hear, sir.
How come no one saw Ebola?
Well, all of these platforms are platforms designed to look for specific syndromes, right? They're syndromic surveillance platforms. So, for example, they're targeted and tailored at the symptoms of flu. And if you look at only online sources, you're sort of forced to a syndromic perspective, right? Because you cannot do virological or microbiological confirmations. In the UK right now, the group of John Edmonds is actually carrying out a validation of the participatory platform they have in the UK, which is called Flu Survey, by actually engaging volunteers into providing also samples to be used for virological confirmation. So if you mark yourself as syndromically flu-like, you get home a kit, and this kit can be used to actually confirm and calibrate the sensor. If you look at the data sources that can provide information about emerging threats, such as Ebola, then you have to look at the health map-like platforms where you try to data mine occurrences of symptoms in the general news and or on top of the standard surveillance sources such as Medicis or systems that are tailored to really surface threat-related data. And you do need a lot of human curation, typically.
Sorry, Ciro, I have to interrupt you because of time. Yeah, we would like to continue then in regard to the questions that are more or less implicit given the potential of those technologies, and therefore we are happy to introduce Jennifer Cole from the Royal Holloway University of London, where she's actually doing a PhD on digital technologies in disease control and containment, and is working on the legal and ethical aspects those technologies are implicitly have. Thank you very much for coming, and we are looking forward for your talk.
Hey, thank you. I'm going to give a quick run through and hopefully kind of pose some questions as well as give some answers on where health data, there's a conflict between the privacy issues sometimes and security issues. And some of the conflict, where those conflicts come from and the challenges they pose. Some of you may be aware of a paper that was written in the early 1990s by Elspeth Ling called European Directive on Confidential Data, a Threat to Epidemiology. And when legislation around confidentiality of data started to come in the early days of the web, there was a strong feeling amongst epidemiologists that some legislation might actually make epidemiology obsolete. It might make it impossible, because the constraints around what you could do with the data would mean that you may not even be able to collect it. If you could collect it, you probably wouldn't be able to use it. And those are still going on today. So I think there are some issues to consider. First is what's technologically possible. And what you've seen from Ciro's presentation, and certainly one thing we've seen in the Ebola crisis, is that what is technologically possible is pretty much anything. If it's needed, technology can largely do it. And when there's a threat, it will start to do it more quickly. But that butts up against what is legally allowed, certainly in the legal frameworks that already exist, what is ethically acceptable, and most importantly, what happens if and when the parameters change. So things that may be legally allowed and ethically acceptable may actually differ depending on the context, and we've seen some of that, again, particularly in the current Ebola crisis. So an example of where legality and ethics might be in conflict is, imagine we had an outbreak of serious infectious disease where we knew that people were infectious before they were actually showing symptoms, and so that they could walk around in a crowd spreading that disease. And we may know that somebody had actually had a diagnosis where they knew that they were infectious and knew they were spreading the disease, and yet still chose to walk around publicly and didn't care whether they infected others. Does that start to change our thoughts about how we might do surveillance, and whether that surveillance actually comes under public health or whether it comes under security? To give perhaps a more positive example, one thing we've seen in the Ebola outbreak is the cooperation between Airtel, the largest mobile network operator in Senegal, and the Senegalese government and the World Health Organization. When they had the first cases of Ebola in Senegal, they basically Airtel immediately handed over every bit of data they had on every bit of mobile phone usage in Senegal to the authorities, so that they could contact trace anybody who might have come in contact with the people who they knew had Ebola. That sort of had a large impact on the fact that the outbreak in Senegal was actually contained and closed down very quickly. So it had perhaps some ethical considerations around the use of privacy data, although Airtel worked very strongly with the international community to make sure they were observing that privacy concerns as much as possible. But it had a very strong public health impact. It did help to shut down the outbreak. So one thing that we can look at in terms of what can technology survey and what does it do? Largely in epidemiology, it surveys where cases are recorded and which drugs are being ordered and used. The AIDS epidemic, for instance, was first picked up by the large increase in the number of drugs for particularly pneumonia that were being prescribed to young men of an age who you wouldn't normally expect to be catching pneumonia. So it's sometimes actually again, perhaps the metadata, the logistics around the disease itself that actually helps to pick things up. But these are very much, I would say in a way, kind of old-fashioned health data. They're things that you understand why they belong in the health sphere, why they come from the public health sector. And they're things that it's easy to understand. What's happening with increased technology is there are other things coming in that again, now we can survey, such as who seems interested in the conditions and symptoms, things like Google flu trends, health map, people are clicking on Wikipedia pages, and also largely we can now tell exactly where those people are located, not only which city they're in, but we can actually tag their computer through its ISP address to their particular home. We can go through records of who owns their mobile phone to find exactly who they are, where they live, where they've been, where they went for dinner last night, who they saw there. And we can also tell from that data who's their social contact network, who are their Facebook friends. Is there a photo on Facebook of them in the pub last night with their friends? So you can actually see who those people are and start to contact trace them. And all of these become very different surveillance questions, dependent on whether you're looking at it from a public health perspective, from a security perspective. So who has a right to that information and in what circumstances? And here again, we sometimes have a bit of a clash because privacy tends to be around the rights of the individual, but this has to be balanced against the good of the community to stop the disease from spreading. And again, Ciro went through very quickly some of the epidemic containment and the mathematics around that. In order to contain an epidemic outbreak, an outbreak of a disease, you have to make sure that each infected person infects less than one other person. And the way you do that is to very quickly tell who has the disease and to very quickly isolate them and stop them spreading it on to anyone else. The World Health Organization normally estimates that around 50 to 60% isolation is effective in containing and slowing down disease spread. So it's very important to find out who people are quickly and to actually try and influence their behavior to isolate themselves as quickly as possible. And again, we have a legal context here because health legislation tends to focus on what should be done, largely to enable somebody to access public health, to protect their own health. And privacy legislation tends to focus on what should not be done, what can't you do with that information. And again, we have the dilemma of who is doing the surveillance and what is it for. This is a very easy question to answer in public health. In most public health laws, and certainly the case in the UK, public health surveillance must be carried out for the benefit of public health. For instance, it can't be carried out just for academic interest. But again, there's another dilemma here around surveillance because public health benefit might be to the benefit of the community, but potentially to the detriment of the individual. So we have health legislation focused on the individual, privacy legislation also focused on the individual, but security legislation is often focused on the many. It's focused on protecting the community from the actions of one or two individuals. And again, within this, if we look at the legal context of health security, most of what we would consider to be health surveillance now really came up from security of the populations at risk. So you can look back to the 14th century, the Vatican started to use surveillance to deny port entry to ships that were suspected of carrying the plague. It was nothing to do with helping the health of those people who actually had the plague. It was to very much stop them coming ashore and spreading it into Italy. And we see that again across the 14th and 15th centuries with quarantine ships all across Europe. And then if we go to the 1740s in America, there was legislation passed that tavern keepers were obliged to report suspected cases of certain diseases to the authorities. So again, if someone came into the tavern with various diseases, for instance, one of which is smallpox or cholera, the tavern keepers were legally obliged to report them to the authorities. Again, it's a breach of privacy, but it's seen as being for the public health good. And that can even become sort of more modern legislation within the World Health Organization into international health regulations, which again puts a responsibility on countries to actually report cases of certain diseases to the World Health Organization for the good of the international health community. And again, we have the legal context for the individual in this. The physician has a responsibility to do to the patient under the Hippocratic Oath, which is to do no harm to the patient individually, and to only use the information they gain for the patient's care. They're not meant to pass it on further to the wider authorities. But again, the physician has a responsibility of the agent of the state. So if they think that someone is a threat or that they have a disease that is a threat to the community, they do have responsibility often to the state to pass that information on. And so again, for instance, the diseases such as smallpox and cholera, they have a legal obligation to report those both to health authorities of their own country, who then have a legal obligation to report them to the World Health Organization. Okay, but there are a lot of countries that, or most countries, have exemptions to patient confidentiality in public health laws. For example, from Public Health Act, to make and enforce such regulations as, in his judgment, are necessary to prevent the introduction, transmission or spread of communicable diseases. There is nearly always, in most health legislation, a get-out clause that allows you to override privacy for the good of the community. And so there are ethical contexts. I've put some examples on here, which you can read quickly, but I'll cut through. What I'd quite like is perhaps a show of hands from the audience. So in ethical context, should doctors be allowed to pass information on patients with sexually transmitted diseases likely to have been caught through engagement with sex workers to the police? Can anybody put their hands up if they agree that they should be allowed to? Oh. What happens if that changes to underage sex slaves to the police? Should there be a regulation, should there be an obligation then to pass that information on? Anybody change their opinion? Another one, should a doctor be able to tell the sexual partner of someone diagnosed with HIV about the diagnosis without the infected partner's consent? That's one that's come up quite a lot of times in the law courts. It could potentially be attempted murder if you know that you have HIV and you deliberately pass it on to someone else. Should the state be allowed to track down someone of having an infectious disease through their online social network? If that disease is lethal, and the people they've been in contact with may die if they don't get treatment within a day or two, don't they have an obligation to actually try and find them and warn them? And I think these are ethical considerations that butt up against each other quite hard in privacy and health regulations. I'm going to skip through most of this. It's the fact that there are get-out clauses, I would say, in most of them. And I would come back to the situation in Senegal. A lot of the privacy legislation that is going through Europe at the moment, and particularly going through the UK, would make what Airtel did in Senegal illegal. It would make it virtually impossible to close down an Ebola outbreak as quickly as that again. And I think that is something with privacy and security and health security that we actually need to take into account. I quite often see with the privacy debate in health data, there's a lot of talk of what ifs and of perhaps not science fiction scenarios, but scenarios where fascist governments take over and will do what they will with that information. I'd say if we really think those are likely to happen, what we need to do is to make sure those governments never come into power, not to actually put mechanisms in place that stop people who can do good with that information being able to do the good they're able to do. No more than we should actually put regulations on biological experimentation that could equally be used for nefarious purposes by governments or scientists who chose to. Is the technology is not actually the owner of the ethics and the legal context, it's the people who use it, and we shouldn't forget that it's a tool, not the means to the end itself. Those are my contact details. Said I haven't looked to answer the questions, I've looked to pose them, but I would be very happy to take questions or to have the debate afterwards.
Well, thank you very much, Jennifer. Please, is there one urgent question in the audience? Okay, please.
On the last point about, what happened with the government in Senegal will not happen here in Europe. Would you take into consideration that here in Europe we would be able to control an Ebola epidemic differently? So the context is different. We do have other means to do that. I'm just asking how this is going to be.
I think I'd argue potentially, I mean, we certainly have a better healthcare system in terms of the contact tracing. For instance, we may have had a situation which I think potentially we may have come close to in Dallas, where we did actually need to do contact tracing more quickly. It could have been a situation that actually someone had come back into the US or to the UK with Ebola, started to show symptoms, chose not to turn themselves into the health sector when they had those symptoms. And that would be a very different situation. And again, I think they are theoretical situations, but I'm posing what is actually possible to do with the technology that we may not want to shut off the opportunity to ourselves to be able to do.
Okay, then I would take the chance and introduce our final speaker, panelist. And this is Martin French, coming all the way from Canada. But I thought, or we thought, it is very important to have him here on board, because Martin takes a specific sociological view, asking, let's say, about the materiality of the governance of public health. And we think this is a very interesting approach, bringing together different ideas about technology, but also in terms of how it is actually practiced in terms of, okay, what are people doing, and not only with the data, but how do they somehow shape the governing of the data. And therefore I'm very, very pleased to introduce Martin French, and I'm looking forward to your talk.
Thanks, Leon, and thanks to you and the RKI for organizing this panel and for inviting me to be on it. So we've heard many fascinating contemporary developments in digital communications. We've heard about how these are affording tremendous opportunity for innovation and disease surveillance, but what risks attend these developments? I think my role on this panel is to raise a few critical questions about these emerging developments in disease surveillance. And actually, Jennifer, you also did a great job of surveying a number of issues, and I'm just going to follow on from you and raise a few questions I think that are kind of similar in some ways to the ones that you asked. So I've only got a short amount of time, and here I'm just going to target my remarks around three critical questions for what I'm calling infodemiologists. And you know, Günter Eisenbach, I believe, was the person who coined this term infodemiology to describe the epidemiology of information. And so I'm just going to riff on this term and use it in a bit of a broader sense to capture all those researchers and practitioners who are engaged in non-traditional, quote-unquote, non-traditional epidemiology, which is to say disease surveillance using non-official sources. And actually, Ed and Tim, you have a great paper in the Milbank Quarterly that talks about indicator-based versus event-based surveillance, and Ed, you talked about that earlier. What I'm speaking about here applies largely to what Ed and Tim and colleagues call event-based surveillance, but as these two modalities of surveillance merge, I think this applies equally to both of them. So, in any case, here are my critical questions. Can or how can infodemiologists promise publics a measure of anonymity in big data-enabled surveillance, disease surveillance? Can or how can infodemiologists address public concerns about the privacy of health-related information? And can or how can infodemiologists maintain public trust as their work practices align or in some senses overlap with organizations that may have lost public trust? So let me start with anonymity. Let me take up this first question. You might say that since at least the mid-20th century, conceptions of disease surveillance have implied a notion of anonymity. At least this is one way we can read Alexander Langemuir's axiomatic assertion that surveillance in public health contexts connotes a focus upon disease rather than individuals. Langemuir's definition of disease surveillance is appealing because it has allowed public health organizations to distinguish their work from, say, the kinds of surveillance that might be undertaken by organizations like the police. And it's also engendered a common practice of stripping epidemiological information of its identifiers prior to dissemination. But as we've heard from Ciro, you know, and Jennifer, you can really find out a lot about people in today's data sets. So how tenable is this distinction today between the surveillance of disease and the surveillance of individuals? Is it still possible to treat data sets used for surveillance as anonymous? And you know, one person whose work questions this is Latanya Sweeney. Her work on re-identification in de-identified data sets is important to consider. It shows how de-identified data can be re-identified with publicly available data when it's matched with this de-identified data. So her work, and there are other examples we could show, illustrate how it's increasingly difficult in today's data affluent environment to maintain this classic distinction between tracking disease and tracking individuals. So, I think that even if steps are taken to strip epidemiological surveillance of identifiers before these surveillance products are disseminated to other organizations, to other actors who need to know, it's increasingly possible to identify, so for example, names of index cases. And this raises, I think, some issues that public health organizations might want to address. Why should we care about this? I think we should care about this because of public concerns over health information privacy. And here I want to ask how infodemiologists can address these kinds of public concerns about the privacy of health-related information. Now, what I'm talking about in this instance has less to do, if you like, with individual concerns about privacy violations and more to do with emerging collective action which protests against the data aggregation practices of health professionals, organizations, and governments. Okay? So we know from decades of public opinion research that individuals care a lot about the privacy of their personal health information. The collective action I'm talking about is linked to this individualized concern with health information privacy, but it's also different from this concern by virtue of being an organized, sophisticated, and critical voice that questions the privacy-infringing potential of aggregations of people's health information. And two examples, I think, that illustrate what I'm talking about here are patient privacy rights in the United States and MedConfidential in the UK. Both of these social movements have mounted challenges to large-scale government initiatives aimed at pooling people's data, pooling people's personal health information. Now, you might say, Martin, those examples are really to do with the data aggregation for medical care and not public health per se. Surveillance of personal health information is very different from something like surveillance of news media reports of a potential disease outbreak, and that's true. However, even if we ignore the concerns about re-identification that I've just raised, I think we still have a problem here, which is one of public perception. The distinctions that public health infodemiologists might draw between their data practices and those involving legally protected, personally identifiable health information may not always be clear-cut for the public. And I think this is especially evident when epidemiological research implicates a particular group of people, however clustered, in the transmission of infectious disease. And there are many examples that we could draw on to illustrate this point. Think, for instance, of the way that epidemiological knowledge has been implicated in the construction of ideas about gay men in relation to HIV and AIDS. If people feel like they could be marginalized by disease surveillance, they may actively oppose it, and then this can hamper, I would argue, public health efforts. So it's an important consideration for infodemiologists to get out front of and address. And I think here, you know, some of the responses that you hear to critiques of statements made by organizations like MedConfidential or Patient Privacy Rights are dismissive, and I think that, you know, there are sort of responses like, oh, they've got it wrong, it doesn't really raise these kinds of issues. I think those responses are actually problematic and fuel the fire, if you like. So I think they needed to be addressed head on. Let me move to the third and last question that I want to raise. How can infodemiologists distinguish their work from that of other organizations that conduct big data-enabled surveillance, such as the US National Security Agency? And I'll address this question under the rubric of public trust. My concern here has to do with public health's potential alignment with organizations like the NSA that have lost public trust. So for example, I think today the NSA probably has never looked more like Big Brother than it does now. When public health surveillance techniques mirror those used by the NSA, is there a risk that it too will take on this aura of Big Brother? A related point has to do with the circulation of analytic techniques across institutional boundaries. So for instance, what happens when new analytic techniques developed for public health purposes are retooled, say, for military purposes and vice versa? And emblematic of this kind of organizational alignment, I think, is the 2008 pilot project undertaken by the US Centers for Disease Control and Prevention, which was designed to test the data fusion concept for public health. Now, post 9/11, the United States Department of Homeland Security invested heavily in data fusion centers. And the goal of this investment really has been to create a network of organizations that gather, analyze, and share so-called quote-unquote threat information. As the Centers for Disease Centers for Disease Control and Prevention, this organizational concept was applied to the problem of biosurveillance. And I don't know if you can see this slide, but it's from a slide deck describing this pilot project. And it involved, this slide is making reference to thinking about potential data sources, reams of data sources that might be useful for making inferences about human behavior, but which aren't traditionally used for public health surveillance. And so, for instance, utilities, surveillance of people's consumption of utilities, surveillance of traffic patterns, incorporating images from video surveillance. This is really trying to think about fusion centers as a public health concept. And the point I'm getting at here is really twofold. On the one hand, there's a public perception issue. What happens if public health organizations start to look like national security organizations? And on the other hand, there's a practical issue. What happens when public health data, I think, Jennifer, you made this point strikingly, what happens when, if public health data could be repurposed to serve ends other than disease surveillance? So I think that's an important question for us to consider here. And I think these two issues would be productively, or could be productively managed by infodemiologists in order to preserve public trust in big data-enabled disease surveillance. By way of conclusion, I'll just collect all of my questions under this rubric of public trust and under the image of Edward Snowden. At first blush, it might not seem like Edward Snowden's disclosures have much to do with disease surveillance. However, to the extent that they have reignited public debate about the contours of the surveillance society, I think they stand to increase public concern about the work that infodemiologists might be engaged in. And so I've tried to characterize some elements of this concern in terms of anonymity, privacy, and trust. That's not an exhaustive list, though there are many other questions that this panel could address. So I think infodemiologists can and must speak to these concerns as they seek to develop big data approaches to disease surveillance. And I'll just end it there. Thank you.
Thank you very much. Okay, we now have the time, like 10 to 12 minutes, I think, to ask questions. Please, Charles.
Thank you very much, everybody, for some extremely interesting presentations. I'm Charles Raab from University of Edinburgh. I wanted to pick up Martin's last point and throw it to Jennifer. How can epidemiologists and so on help to pick their way through some of these ethical and legal dilemmas? And I would suggest, and here's a suggestion, an observation, which then will lead to a question. You might be able to help this, Jennifer, if you wouldn't caricature the definition of privacy as being simply about individual interest, which stands against something called the collective good or the public interest. By now, there is quite a lot of very important philosophical thinking and social science research which tends in the direction of showing that privacy is also a public interest value and is not just an individual interest value which can be trumped by appeals to the common good against the mere individual who's holding out and waving a flag of rights. And I think that that debate amongst epidemiologists really would be much more enriched. It would encounter more complexity in trying to resolve these dilemmas, but at least it wouldn't caricature the idea of privacy in the way it has habitually been caricatured in that field. My question that I want to lead to is, in your opinion, do the articles, and I think that they're articles 83 or 85 in the draft data protection regulation, which has so excited the public health and epidemiological community, do you think that they really are the sorts of pieces of legislation which would put an end to public health and epidemiological research? Or is there a sense of over-egging that argument and crying wolf?
First of all, I'd say, I mean, obviously in a 10-minute presentation, we inevitably have to make generalizations. I certainly do think it's the case that within health data in particular, there has been a kickback, particularly in the UK, from a privacy point of view that has closed down and prevented what would have been some extremely valuable NHS databases and data sharing by lobbying from the privacy lobby to the general public who didn't really understand the complexity of the issues. And I think actually there is a wider debate to be had there and to explain from both sides the issues around that. I mean, I think in terms of surveillance, certainly in this context, as I said, I mean, some of the scenarios I'm working on, they are very academic, they are very imaginary scenarios. But I think it definitely is worth having the debate around what are these issues and what would the situations be in which this might happen. I mean, it's interesting, the lady behind you said the context is different in Senegal. I don't see it as being that different, actually, and I think, again, it's a very generalization to say that's Senegal, it's different, and we're somewhere else. Certainly, I mean, the question that we had earlier again of why didn't we spot Ebola, the World Health Organization would say we did. Médecins Sans Frontières would say we did. And nobody listened to them when they shouted about it. You're also operating in ICT environments where actually some of what we consider to be surveillance that can be done very easily is very difficult to do in those kind of contexts. And so I think there are all the issues around this. Is the data valuable immediately in real time? Is it something we look back on? And we look historically. There's certainly, I think there's an article in the Lancet last week, if not the week before, from authors who were making the points that actually now some of the research they're doing has to be done on historical data because they don't have the level of information in the data anymore that was there in records made in the 1920s.
All right, I will take the chance to have a few more questions collected.
Can I just have a quick rejoinder on that?
Sure.
I think you veered off my question into a reprise of your talk, but my question really had to do whether you think that Articles 83 and 85, if those are the relevant articles, are going to stop the show as far as epidemiology and public health are concerned. I mean, it seems to me that the instance you gave about the NHS and so on, one of the things that this debate has engendered in the UK is a much more creative approach to thinking about information governance and systems of ensuring public trust. And we notice this in Scotland, where there's been quite a lot of development of that kind of stuff, precisely because there's been a challenge to the way in which health data and public health data are collected and used.
Okay. Atta, short question, please.
Just a quick one. The stress testing of any law, procedures, rules, in terms of their being balanced, must be, to consider extreme cases where, we might be subjected to biological warfare and of communicable diseases, and on the other hand, where a disease is not communicable at all. And so I think the two differ. Contagion seems to me to be a defining predicate here, and it doesn't, it is not possible to consider the same privacy or liberal privacy preserving or liberal sharing of data, which is appropriated to different disease contexts. You have to look at the context. So I wonder whether you comment on that.
Okay, Martin, maybe.
Yes, I agree. I agree that context is very important. Much of a lot of the developments that we're seeing in, if you like, big data-enabled surveillance have to do with detecting infectious disease spikes. So, I think, but there are certainly questions to be raised about the priority of a focus on infectious disease surveillance. I don't think that if you take chronic illness, surveillance of chronic conditions, I don't think that the privacy issues go away. I think they're different. So to give you an example, I know a researcher who is data matching people's consumption patterns and obesity rates in neighborhoods. So this is an example of gathering pretty detailed information about people and relating it to inferred health statuses that I think raises important privacy concerns and questions.
Okay, further questions, please, from the audience.
Sorry, if I could just add things that, I think the context is important because certainly, I mean, my interests have been very much in serious infectious disease and naturally occurring serious infectious disease. But for instance, another debate that's come up often in the UK is, for instance, should there be a link up between supermarkets that have information on people's buying habits from their store card and the national health so that they can see where they may need to target, for instance, diabetes needs in 30, 40 years' time, because there are areas of the country where they know people have a much less healthy lifestyle than others. Now that actually you can do that without that information being linked back to the individual. So again, that's a privacy issue of the individual or the community. You can say that this town has a poor diet compared to this town, and therefore this town needs more resources into diabetes. So I think it is very dependent on the context and actually at what level then, perhaps again of the granularity or the level of privacy may it be useful to go down to.
Okay, other questions, more questions. So, please, yeah. Maybe you can stand up because we are running a little bit out of time.
Thank you, Janikas from Panopticon Foundation. We are NGO protecting privacy from Poland, but I also make a PhD on the right to health at University of Warsaw. So for me, right to health and privacy, they are not opposite values. There are common values which protect human dignity, and I don't like to put them opposite, which I think it's very important. I would like to say, to answer what Jennifer said, that the main concern from the privacy issues to that data can be used from other purposes, for example, for a government which is totalitarian or something like that. It is not only like that, because we also measure privacy infringement from the proportionality and necessity perspective, and from necessity perspective we also have to compare if this measure is the best measure to achieve our aim, is to protect, for example, health. And we have perfect examples from the 1980s, from HIV pandemic, when government introduced very strict measures against groups which were vulnerable, and that day those groups were so frightened to go to doctor that it was counterproductive also from the healthcare perspective. So we have to think also from many different ways and to see that privacy and health can be both very important and not as opposite values. Thank you.
So this was more a remark, comment, I think.
Event.
Yeah. Ed, do you want to somehow reflect on that, or from your organizational point of view?
I don't have much to add. I think it's a valid point, and drawing on some of our history is very important. I think it's a point well made.
Yeah. All right, then, is there any other questions from the audience? Then I would like to take the chance and ask a question to Ciro in the end, because I think this distinction between the individual and disease, even though it's problematic to pose it. But I would like to know, okay, you know, when we talk about big data and, you know, all the potential of big data, and we consider also, you know, this distinction between, you know, do we relate the data to an individual or do we relate the data to whatever it is in the end? So what can be done statistically, what can be done from the mathematical point of view in regard to the question, how deep do we go? Yeah? Do we reach the personal data in terms of I can relate it to a subject, to an individual? Or can I somehow use the idea of big data to somehow aggregate on a different level, where I somehow, let's say, obscure what is on the individual or even on the group level? I don't know. Maybe you can give us an idea about it, and that would be my question. Thank you.
This is a difficult one, so I'll be very quick. There's an entire line of research on privacy-preserving data mining methods. And the idea there is to be able to compute some things on top of personal data without actually ever disclosing those data to the output of the computing system. There are also ways of exchanging data in forms that are encrypted or obscured, but still amenable to computation, to statistical computations. And these transformations are designed in such a way that on the receiving end you cannot reconstruct the original data. But you can still compute a bunch of distributions, a bunch of statistical observables on top of that. So that's one way which is an active area of research. The other approach is one of scale. Depending on the questions, you may need or not access to the resolution of individual behaviors. For example, if you want to forecast a pandemic, this is typically not needed. What you can get away with are fluxes from, and data from infrastructures. Now, there are difficult issues even in terms of sharing fluxes. So for example, during the onset of the current Ebola crisis, there was a request voiced by several leading modelers worldwide that specific phone operators active in the areas affected by the epidemic would share aggregated data about the mobility of people in those areas from mobile phones or from other proxies of behaviors in order to assist modeling efforts, and this didn't happen, right? So there are reasons why this didn't happen, but I think there needs to be a reflection there, and there are ongoing discussions also on considering data collected as a side effect of mobile phone operator activity as a sort of public asset in terms of creating an obligation for the operator to share this data with some public agencies so that they can, just like the way you share maps, in a sense, right? So the point is that a lot of the maps that are relevant to an effective intervention today are not just topographical, geographical maps. They are maps obtained by aggregating behaviors. And as long as you can create an aggregated map that loses the resolution of individual behavior, you're more or less fine. But there are a lot of situations, especially when you want to validate interventions, or where you're in a containment, in a very early containment stage, and you need to do contact tracing, where actually you do need to resolve individual behaviors, and there you need to be able to create connection between systems that are not designed to talk to each other for very good reasons. So I would say it really, I mean, there's no one-size-fits-all answer to your question. It really depends on what you need to do with the data. We can do a lot in terms of forecasting without personal data, but if you go to high-resolution social network, contact networks, and nosocomial pathogens, you need to be able to link this data to the electronic health record, for example. So depending on where you are in the spectrum, different kind of problems arise and different balances arise as well. And I recognize this is a very partial answer. So,
okay, thank you very much. I have the idea to ask a final question because. Oh, okay, sorry. Okay, then we have to do that. I didn't know. I did know, so okay. Thank you very much for your attention, and thank you very much for the organizing of the panel. panel, the Robert Koch Institute, and thank you very much. Bye-bye.